everyone. Welcome to the Top Pro Health panel discussion on the topic under pressure hypertension in women. Hypertension is otherwise also known as the silent killer, which affects almost 21% of women in India. In Apollo database, we have conducted an analysis and we found that around percentage of high school students and around 19 college students 9% of the high school students and 19% of college students are pre-hypertensive. And among the adult population, about 8% of the women less than the age of 40 is hypertensive. And before menopause, about 15% is diagnosed to be hypertensive. And 40% of uh, women after the age of menopause, after attaining menopause, is diagnosed to be hypertensive. So this is an alarming data and it has implications on many aspects of the health. So hypertension is mostly, it goes as a silent disease without much symptoms or like symptoms like headache or anger issues and all, which is mostly taken care as normal or not pertain, more not inclined, indicative of any disease as such by the public, so it is mostly unnoticed and silently it hits the heart or the brain as a stroke or a heart attack. And that's when the all of the sudden it comes into the picture. So here today we are going to discuss about hypertension, especially in women, and discuss what can we do in order to increase the awareness to what are the preventive steps and some aspects about the management also. So here we have our esteemed panelist, Dr. Girish V. Navasunti, the lead consultant cardiologist at Apollo Hospitals, BG Road, and Dr. Surpreet Kaur Sandhu is a senior gynecologist at Indraprastha Apollo Hospitals, Delhi. And they will help us to discuss these topics so that we can have strategies and to get better awareness and prevention and management. Thank you, doctors, for joining us, and let's start our discussion. So, first, Dr. Girish, my first question is towards you. How common is hypertension in women when you're comparing it with the men, and what age group is most commonly affected?
Yes. Um, Thank you for asking me to be on this platform today. And Apollo is a great knowledge source for people. And I'm very glad to speak to my colleagues who primarily look after Pro Health. I think Pro Health is a great initiative to detect any disease, means any problem of health very early in the course and have a early management strategy and a periodic follow-up. Now, coming to hypertension, we know among all the diseases, hypertension is going to be probably the number one reason why people will have premature death, repeated hospitalization, or poor quality of life. That's going to be the first and the foremost cause for heart failure, stroke, myocardial infarction, and even death. So, looking at that, we know hypertension is usually divided as idiopathic or a secondary hypertension, or primary hypertension or secondary hypertension, where it manifests secondary to some other disease such as renal artery stenosis, adrenal tumor, or something like that. Coming to idiopathic hypertension is quite common and it's increasing as the in the recent times because of our lifestyles as well as the obesity. How common is it? I think it's becoming more and more common in urban women. The most common time for it to manifest is post-menopausal. Estrogen, as long as their ovaries are functioning, their women are usually protected. But even these women, if they become obese, sedentary, or consume excess alcohol or tobacco, or if they have any other associated problems such as PCOD or other issues, there could be increased prevalence. But we are mostly concerned about people in their fourth decade, fifth decade, and sixth decade. These are the people who tend to have hypertension to an extent of about 10 to 20% of them. So it's important to screen them very periodically and manage it better.
Yes, sir. So, Dr. Sutpreet, as you are dealing with most like the young women, young mothers, like sir has said that it is more, it is in his practice he has seen people who are more diagnosed with hypertension ladies, especially at the around perimenopause and postmenopause age group. Since you are dealing with young women, young pregnant ladies, how common is the hypertension diagnosis in your practice among the young mothers?
Thank you, Rosa. Thank you so much for making me a part of this presentation today. And I'm really, really happy to be here. I'm totally obliged. Dr. Susan, the thing is that Dr. Girish has, I think so, he's covered nearly all the parts which are to be covered in menopausal age group. Yes, in the fourth decade and the fifth decade. When we are coming to the younger ladies, uh, one of the most important thing which is to be understood is because I am there in Apollo Health Check, and definitely not only the pregnant ladies, all the females above 15 years of age, all the way till if I'm considering only 15 to 38 years or 40 years of age, it is the lifestyle because of which we are having so much of lifestyle. Now, hypertension, if we are talking about hypertension, yes, this percentage has increased by leaps and bounds. First, because of the lifestyle. Second, because of the tobacco consumption. Third, because of the alcohol consumption. And fourth, and I think the most important thing is this emotional and the physical and the mental stress which these girls and females they take. Maybe it can be because of familial reasons, it can be because of the professional reasons. But if we are talking only about the females, those who are in the younger population and they are becoming pregnant for the first time, nulliparous. Nulliparous means they never had any abortion. I'm not talking about whether they were pregnant and they delivered a baby or a live baby or no. They were never pregnant. Nulliparous females, they are having higher chances, and it is round about 7 to 15% of the nulliparous when these uh, women they become pregnant, 17%. That's the maximum. They get hypertension during pregnancy. So that is gestational hypertension we are talking about. But then again, it is subdivided into very many categories. Dr. Susan, the thing is that if these females, they are having if they are not having gestational hypertension and they were hypertensive before pregnancy, so then of course everything, all the datas they change and all the percentages they change. But let us just be concise. So, in the younger population, nulliparous, 5 to 17% of the females they do have during pregnancy. We see. Else, the normal population, the percentages are rising every day because of the reasons I've already mentioned. So,
Thank you.
Great. As you mentioned about the different risk factors for developing hypertension in young and Dr. Girish had mentioned about different risk factors for the adult. I think the stress factors have also increased among the ladies of like most of them are working in high-end professions with almost like that itself is a full-time job, and along with that they have other familiar responsibilities, social responsibilities, and that even increases their mental stress also, and awareness about how to deal with them or how to deal with all these stress factors is also not be considered as a priority by the individuals, and maybe that's also one of the factors. Also, I think there is a lot of like smoking and drinking habits is increasing among the Indian women comparing to the past decades. So, especially smoking is a very high risk factor for all this, aggravating the complications of all the genetic factors which can contribute to the hypertension and other non-communicable diseases. So yes, the factors which are modifiable and non-modifiable factors are there, and we have discussed about those. Dr. Surpreet, about the we have talked about the young ladies and the perimenopausal age group ladies also. So what about the young kids, the puberty age group? So do you find any an increasing trend of pre-hypertension or hypertension? Because in our Health of the Nation report from Apollo data, we had around 9% of the high school students. That's both the men and boys and girls. So 9% of the high school students had hypertension. Any view on this, Dr. Girish or Dr. Surpreet?
Uh, Dr. Susan, the thing is, if we are considering kids as kids, like not gender bias, the problem with all the kids nowadays is the screen timing. Their screen timing is increasing. Obesity and hypertension, they go hand in hand.
Mm.
So even if hypertension, if we are trying to find out hypertension or pre-hypertension, if we don't directly go there, and if we think and if we discuss on obesity, obesity is on a rise. It's on a massive rise. The problem with the kids, no matter, maybe it's their studies, it can be related to their studies, it cannot be related to their studies, or that can be just their idle talk, or they can be it can be related to their idle time. The most of the time when they are there on screen, that increases the obesity chances. Of course, bodily, they are getting obese, they are getting fat, and that is the precursor of hypertension. So that's why I said these are the kids when they grow up, when they are entering into the second, like after 20 years of age, why there are pregnancies, and why in the previous 20 years back or 25 years back, we never had this data of having nulliparous females of 20 to 35 years of age having 17% of gestational hypertension or primary hypertension, chronic hypertension. The data has increased. This percentage
Mm.
has increased, and that is because the foundation is set while they are in their teenagers, when they are there in their school. So 13 years onwards, obesity is the screen timing, loss of physical activity, no dietary modifications, fast food, and I think so. Again, all this will boil down to the same thing. The three, I tell all my patients that your health is getting it's balanced on a tripod: physical, mental, and emotional stability. So if that is not there, and whatever I have said as of now, everything is going to, this is the precursor. This is the precursor of all these. Everything becomes unstable. Your physical, you are not moving. There is no lifestyle modifications, dietary modifications are not there. Because you are not performing good at school, you're having mental problems. Because you're having mental problems, you come back to home and then you're having all your peer, your kins, and they are saying, then you're having your emotional disturbances. So what are we expecting when these kids they grow up? This is what is happening as of now.
Okay.
Yeah.
Yeah.
If I
Very
may
true.
just summarize briefly, as excellently put across by Dr. Supreet, what I would like to say is it's part of it is genetic, but majority of it is lifestyle dependent, right? We all know children are supposed to be children, not grow up so fast. Children ought to be very active, eating very healthy. That practice gets brought about by parents' lifestyle rather than the children's lifestyle. Today, most of the parents, both of them work and they have little time to genuinely have a healthy diet for their children, healthy conversations, healthy physical activity there with their children. That's a challenge. Children are becoming adults or adolescents very, very fast due to both social media as well as the access they have. I think same information what you have, they have. So there's no age gap in that. And, the access to unhealthy food has become now with the instant delivery apps. I'm ashamed to say even my children, uh, in 7 minutes, something get delivered home. So they don't even check what is inside of it, right? So we are living in times when you expect disease to start early, progress faster, and damage the organ in a much younger people. So we need more of these endeavors to tell people how we need to change and influence the children, adolescents, young people not to become hypertensive. So it is going to be a reality, but it has to start with the parents being involved in it.
Yes, very true. Like, as we all are parents, and we see that, like, when we compare the accessibility to the fast food and the screen and the and attitude also, that they think that's part and parcel of life. One, like, for example, like KFC chicken or a McDonald's is mandatory in a weekend. It's like, why it is not there is the question. Rather than, once it was a luxury, now it's like it's a right for the kids. Like, it's
Yeah.
a, I think it's a, uh, both the parents and the society as a whole has to take up whole community to bring a child actually. So yes, as parents, doctors, especially even if we are doctors, we have to. This is like a mirror on ourselves, like to reflect on this. And moving on, Doctor Girish, like if when you are diagnosing a patient to be hypertensive, or like you feel, you know that the last couple of BP readings are high, and you break this news to the lady or the patient as such, with a man or woman. How is their response, and how is their adherence to the medication? What is the usual
Yeah.
trend, and what are the difficulties if there is any, and how do you address that?
Yeah, I think, a doctor is like a parent. Talking to the patient is like talking to a child, right? They come with their own anxiety. They hope that they do not have any problem, and they think you're finding something and going to compel them to change something about them, or make them take some medicines which make them a patient which they were not before they meet you. I think that is where you have to evolve into that human being who talks to them like a matter of fact, like a family, or someone who can, who's truly interested in their well being, not just prescribing change in lifestyle or medication. And with what calmness, with what clarity, with what absolute measurable, parameters you can guide your patients to take ownership of their problem. That is what makes patient stick with your advice. Majority of the doctors will write the prescription, but that is not going to translate into good management of hypertension. So primarily you asked me three questions: how do you diagnose, how do you communicate, and how do you treat? These are three different things. I think diagnosis, there are set protocol. You should ask people to come 30 minutes, wait, rest, no coffee, no television, 15 minutes of sitting, then check your blood pressure, sitting.
Uh, Dr. Girish, we are not able to hear you. Is there any net problem with your side?
But Susan, there is no problem. I'll continue with that. The thing is, what
Yeah.
he was trying to explain was when the person comes, whenever we are going to diagnose, first the diagnosis, second the medicines, and third is the adherence. So adherence, he has already explained that until and unless you're not going to make patient yours, and until and unless the patient doesn't understand what is going to happen if he doesn't take the medicines, he's not going to take the medicine. So first, let the patient understand. Second, how do you take the BP? how do you make the hypertension diagnosis? So the patient has to be there in the clinic, as Dr. Girish was already saying. He has to wait. He or she has to. They have to wait. They have to be in totally rested condition. No screens, no coffee. They shouldn't be like, they. If they have come, let them be sitting. Let them, if possible, at least 10 minutes of sitting, and then take BP both in the upright position and preferably while lying down. And these two measurements, they are to be taken. Basically, how do we diagnose BP in females is that any reading which is above 140 by 90, 140 systolic, 90 diastolic, there should be two readings at least 6 hours apart on two occasions, not more than 7 days apart. That means within a week. Now, if this thing is persisting, then we start the medications. And when we start the medications, our goal is to have the BP less than 150 and 100. It should be maintained between 150, 140 to 150 and 100 to 110. Sorry, 90 to 100. Anything else, then the combination therapy, it begins. You go with the single drugs first, be it ACE inhibitors, it can be calcium channel blockers. When pregnancy comes in pregnancy, only and only we go with the, labetalol. So it is alpha blocker and non-selective beta blocker. So it is one drug which is having very less side effects in pregnancy. The second line of treatment is nifedipine. And the third line of treatment is methyl-dopa, depending on how your patient is responding. So this is for the females, those who are pregnant. And any person who is having in the non-pregnant females, be it young or be it old, the BP, the if the BP is maintained, very well and good. Otherwise, you go for the combination therapy. And the best thing, or what I think is the best, is when you have diagnosed hypertension, we try not to linger it on, and we try not to have that person with the same readings for a prolonged period of time. What I mean to say is, you give the medication and you treat it in time. This is known as a time, there is a uh, Dr. Saab, if I'm not very wrong, there is this one theory which is known as time theory. So you have a window period, you give the medications and you give full shot so that you don't have those elevated BP or readings for a prolonged period of time. And that is how this is how the management is done. And definitely the follow-up is there. Follow-up will depend upon if the pregnant females, it is they have to take BP while they are there at home, and that is it is no the two BP readings, they should not be more than 6 hours apart. So at least 3 to 4 readings in a day. This is the least that can, according to the control of the BP. And if the BP is not being controlled, the pregnant patients, they are admitted in the hospital. The BP is
Yes.
controlled, they can be there at home. If it is not getting controlled, they are admitted in the hospital, both for the female, for the patient, and for the BP. And for the younger age group or the older age group for the females, for any BP, again, it is the follow-up is indicated, definitely 3 monthly, 6 monthly, 8 monthly, or yearly. That depends on the BP readings, how that person is responding to the treatment. I think so, Dr. Girish, if he's back, I've taken, he's back?
He was there in between, and meanwhile he had to, I think again, Dr. Srividya has joined. Hi, ma'am.
Hello, sorry, apologies.
Hello, Dr. Srividya, how are you?
Hi, Dr. Zulpreet. Hi, Dr. Girish. Thank you so much for joining. Please continue. Don't stop on my behalf. I'm here. Thank you.
Yeah. Ma'am, again, the other question is there any relation to the oral contraceptive pills or hormone replacement therapy and hypertension?
Uh, Dr. Susan, if you are asking about the relationship, the correlation, the thing
Is
is
it
that
like any
when we, yeah,
yes,
please, 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 please,
continue.
uh, please continue. I'll
Yeah.
answer.
So is there like oral contraceptive pills and hormone replacement therapy? Like, is it a risk factor for like developing a hypertension, or is it like a help for not developing hypertension?
Dr. Susan, there are two parts of this question. First part, OCPs, that is oral contraceptive pills, and HRT. So both of these, they are used in the different age group. So I will answer age-wise. In the younger age group, when you are taking oral contraceptive pills, as I've already said this, I'll reiterate the same thing again. If you are gaining weight because of the obesity, you are you are getting a precursor of hypertension. It is because of the obesity. And then very many times, oral contraceptive pills, normally, it is in the normal language, very many times the people they say, hame suit nahi kara. Now that suit nahi kara can be very many things. It can be some, borderline diabetes, which was there before, which was not diagnosed. And again, because the hypertension, nowadays, oral contraceptive pills on any prescribed consultation paper is going down by leaps and bounds because female condoms are available. And it is always better for the females to not pop any hormones until and unless it is really not needed. For only contraceptive purposes, there are other methods.
Yes.
When we are coming to HRT for the hormone replacement therapy, Dr. Susan, we never take hormone replacement therapy for these diseases, for diabetes or for hypertension, so that the rate of the in the researches, yes, we have seen that the females, those who were on HRT, they had lower CVDs, cardiovascular diseases. They had
Yes.
lower percentage of myocardial infarction. Yes, they, but that was the researches which were performed on the patients, those who were taking HRTs not for these diseases, but they were taking HRT for their post-menopausal symptoms. And those post-menopausal symptoms, which are like dire symptoms, they were having sleepless nights, insomnia, and so on and so forth. So they took it for that. HRT is never to be taken for decreasing the chances of CVT or hypertension or MI in the elderly age group.
Yeah,
So
it's like
this is,
a add-on thing to that.
yes, yes.
Yes. And Dr. Surpreet, like as you said, like the risk factors always come down to the obesity, and the obesity is one of the common risk factors. And when you see on the PCOS is also on a higher trend, and these girls are having issues with weight. Their weight management is difficult, and they have issues with fertility. So they take treatments with hormones, so that is also an add-on risk factors. So, how often do you see like hypertension, and how is the management with the hypertension and PCOS together?
When a person in the younger age group is coming, and if the Dr. Susan, first of all, PCOD and PCOS, both of these terms, they are seldom used nowadays.
Mhm.
Polycystic ovarian disease and polycystic ovarian syndrome, we don't use these terms now. We use polycystic ovaries.
Oh,
It is surely not a disease. And of course, the syndrome now they have divided that thing also into like, very many subgroups. So uh, uh, the the most normal or the most easiest way of using this term is polycystic ovaries, and this is a radiological diagnosis. Now,
Mhm.
again, if I talk on this PCO, it will just take the whole of the session. So I'll just keep myself to this question of yours that whether PCO and hypertension they are related, yes, they are related. For again the same thing, because PCO is resulting in the females, those who are having again no lifestyle changes, they are having no physical activity, and there are no dietary changes with those females. They're having not unhealthy diets, and also this is where the PCO, those who are taking treatment for infertility, or the PCO, those who are having obesity, or the PCO, those who are having hypertension. This is how the PCO is the common factor in all of these. It is very much possible that a PCO person having all of these is having a very normal period. They're having very good menstrual cycle. So telling them until and unless they are not going, if a person who is lean and thin, she goes and she gets her scan done and she is diagnosed as PCO. First of all, this is what Dr. Girish was saying. Dr. Girish was saying that first of all, you have to convince the patient that the patient came as a normal person, but the patient is a patient. That convincing, it takes most of your time. Most of my time it goes in cleaning the ledger which has been laid before coming to my clinic. Patient says, I've had regular periods all my life. I don't have any problem. How can I have PCO, and why? Because of that, I'm having infertility. So that again, it is just going to it's a whole different topic to be discussed. But definitely, hypertension and PCO, they go hand in hand in most of the times. But because of the common factors, they can have diabetes also. They can have borderline. They can have insulin resistance also. They can have obesity also. They can have hypertension also. And again, for them, this is how, when they are entering into the conception time, the preconception counseling becomes very, very important. Here is where the preconception counseling comes. Because in preconception counseling, we will be 100% sure that whether the patient at present is hypertensive. So when she is getting into the pregnancy, as I said before, you have to treat her, and you have to treat her good. So that when she is entering into the pregnancy, she is normotensive. We try to do that. If a person is there in pregnancy, that is known as chronic hypertension. If a person is there with hypertension and she is going into pregnancy, that is chronic hypertension. And these patients, they are having much more chances of progression to end organ diseases during the pregnancy. So that is not good. If they are hypertensive, that should be treated as soon as possible. And if the patient is of higher age group and they don't have that much of time, then definitely the medical therapy has to be started, as I stated earlier. So whether the combination therapy is there or whatever, that has to be started. It has to be taken care of.
Okay, ma'am. Thank you, ma'am. Dr. Srividya, ma'am, I have a question for you since Dr. Girish had some issues with connectivity. Like, is there any specific like choices, like especially in the fertility period or so, when we choose an antihypertensives for the woman?
There are, when we look at the antihypertensive, the medications for the blood pressure, we choose something which, one, will not cross the blood-brain barrier, will bring down the blood pressure lower in the women's system itself, and it will not affect the cycles and all. So we essentially choose to use either the calcium channel blocker or the beta blocker. We do not use anything which is metabolized by the kidney. So the ACE inhibitors, the ARBs are not used. If you need, some people like Dr. Surpreet was saying, some of them who have got chronic hypertension, who need multiple medication to keep the blood pressure down to as low as 110/70 or 120/80, there are alpha blockers also which are used. In fact, alpha blockers are the drug of choice during active pregnancy. Because the calcium channel blockers can cause fluid retention. The beta blockers cannot be used in women who have either wheezing, asthma, COPD, or who have diabetes, because it can mask the low sugar level. So alpha blockers automatically become the drug of choice. So these are only these three things which are used. There are very good cardio-specific beta blockers again, like metoprolol, sotalol, and all, which are labetalol, which are very actively used by the gynecologist during active pregnancy.
Ma'am, also like thyroid diseases, hypothyroidism is also more common in females than in men. So hypothyroid, hyper or hypothyroid and hypertension. So how is the management done in such situations?
So hypothyroidism for women for multiple reasons itself has to be under very good control. And we have very strict, so we want to keep the TSH between 2 and 3, whether they are planning pregnancy or not. In fact, we go very aggressive with trying to bring the thyroid hormone up to level if somebody is planning a pregnancy. Any blood pressure reading, if it is high and the thyroid markers are off, we have to correct the thyroid markers, wait for the body's metabolism to kick in before we up the ante for the hypertension. We can wait for, there is no point in treating hypertension if you're not going to correct the thyroid for any metabolic profile, especially for hypertension. Many times when you are correcting hypothyroidism, the fluid retention goes down, the metabolism kicks, the person becomes catabolically active, and then the blood pressure, if it is a marginal rise, will come down. We will get a clearer picture on the hypertension once the thyroid is corrected. If it is hypothyroidism, the TSH is under good control, the blood pressure is all over the place, then it is purely hypertension. We need to work on that.
What are the future digital advances in blood pressure monitoring that can be used, especially like home BP monitoring and all? It's already there. What are the latest advances which we can discuss here?
Yeah, so we have to understand that the blood pressure monitoring is done at multiple levels. No, we can check blood pressure at your fingertip, you can check it at your wrist, and the conventional where we check it at our arm level. Each of this has a little different parameter. Whichever form of digital blood pressure monitoring you are going to use, we have to remember that they are electronic gadgets and they need to be monitored also. The most important part of any type of home blood pressure measurement, it has to be standardized with the existing normally working hospital sphygmomanometer or the BP apparatus, and then we should know. So we should know what is the difference, if it can, and those parameters can be adjusted. The newer one which are coming are the wrist gadgets, which automatically check the blood pressure, but the standardization has to be done even for those. There is a chest monitor which is coming, which is being used by all these marathoners to check their blood pressure when they are running. Very, very effective, but it has very short-term effectivity. You cannot use it. It is based on the ambulatory monitoring method system, actually. But it is there, yeah. But nothing beats getting your blood pressure checked with the physician or with your treating doctor.
So before we closing, any take-home message for the physician and the public, both Dr. Srividya and Dr. Surpreet?
Dr. Surpreet, please.
What is Srividya first? I was about to say.
So, okay. I think women live in constant denial about their own blood pressure and that the increasing blood pressure among the family members and all. So the scare or the worry is that if I start taking blood pressure medication, then I have to do it for life, is something which we hear a lot. So my thing is that you have to take blood pressure medication if your blood pressure is persistently or 3 times recorded to be above 140/90 in a very calm and collected manner. It's very, very important that we accept that my blood pressure is here to, high blood pressure is here to stay and I need to treat it. Lifestyle changes goes a long way in bringing down the blood pressure and the medication requirement. But if somebody is very symptomatic and the blood pressure is persistently above 140/90, a low dose medication goes a long way. The third thing is that we need to understand if the blood pressure is not treated, it is going to cut into complications as you grow older, and that is not what you want. Menopause is one of the most toughest part of a life to handle with high blood pressure because it has a lot of hormonal ups and downs. That is, and essentially we have to remember that 90% of hypertension is asymptomatic. It just gets picked up when you go to your GP or for a health check on a regular basis. So that's from my side. So Preet.
Satwik, ma'am.
Hanji, Hanji. Dr. Susan, the thing is that, as Dr. Srividya correctly stated, that menopause is the hardest part. What I tell all my patients is you spell it or you read it as for me, no pause. This is how you have to read it. For me, no pause. That means you don't have to compromise on your lifestyle. You don't have to compromise on your physical activity. You don't have to compromise over your eating habits. You don't have to compromise on your any of your dietary changes. If it is needed, it is needed. You have to do it. Because the foundation of your home, of your whole, your life and your family members is you. If you are good, you are fine, you are keeping everybody around fine. So, as Dr. Srividya said, it is going to go for a it goes a long way. Lifestyle changes, dietary modifications. This is the basis of it. How your plate looks like before you eat, this is how you are going, basically, whatever you're putting into your body, this is your input, and you will be getting the dividends in the later decade of your life. This decade input is the dividend which you get in the later decades of your life. So it has to start right from the teenagers, and it will start only when the mother or the parents, to be precise, if they are taking care of themselves, the children they will be taking care of, and then of course everything is going to fall in place. So the most important thing is the female has to take care of herself, and the denial. Dr. Srividya said this, denial is this is such an important thing. This is what I'm saying. When a person comes, it becomes near about impossible for us to make that patient understand that they are having BP. That ledger which has to be cleared, it takes much of the time, but this is how it has to be done. So, first, acceptance. Second, medication. Third, follow up. Fourth, kindly take care that when you are there with the doctor, do as the doctor says. And fifth, and not the least, and the most important one, kindly go for the regular health checks. Because that is the time when it is picked up again, as Dr. Srividya said. So, these are the 5 points. That's it.
Thank you.
From my side.
We have a couple of questions. Can we discuss that?
Yeah,
Please.
sure.
So the first question is, I take Patanjali medicines from last 3 months. Earlier, I used to take allopathy medicine, but still not able to manage my high BP. What should I do? My BP is 180/100.
If your medication has been high on a single medication, it needs to be either the dose of the medication needs to be changed, or the medication needs to be changed, and it needs to be iterated. It has to be set, because some hypertensions are difficult to treat. I have no opinion whatsoever on Patanjali's medication. I am not qualified to talk about it, but it is always better that the longer you leave the blood pressure untreated and unchecked, the complications are going to set in faster.
So the second question is, I am on TELSAP and all the other necessary hypertensive medications, including diuretics. Still, my BP is very high. And despite changing medication, it is the same. How is that possible?
Probably they need to check the BP apparatus which is being checked. Is it the doctor? If it is only telmisartan, you can go on. If the medication has been, like I said, adding 2 or 3 medication together will various ways of bringing the blood pressure down, it will work better for this person. We also need to see what are in the lifestyle. What is your caffeine intake? How is your sleep? How is your HSCRP? Are you overweight? Are you obese? A lot of these lifestyle things have to be checked. And of course, we have to check whether the medication is effective for you or not. And please go back to your doctor and discuss these things.
Yeah. So next question, Dr. Surpreet ma'am. I had a gestational hypertension. It was managed well with medication. It is normal now. Am I at risk for hypertension still?
Dr. Susan, now what she hasn't mentioned is whether it was a gestational hypertension or was it a chronic hypertension. If it was gestational, I'll explain both of them. So if it was gestational hypertension, and gestational hypertension is defined when postpartum, the BP becomes normal. So the risk factors in these cases are less for her developing hypertension in the later part. Yes, it is less. But chronic hypertension, if it was she was hypertensive before, she is going to have those hypertension again. And if she doesn't control, and if she doesn't take medications adequately, and if the readings they are not in range, and if the readings are high for a longer time, for the longer period of time, end organ damage is likely to be higher in such cases.
Correct.
So if the pressures are high, she has to take medication, and a proper follow-up is to be done. And if it was a gestational hypertension in the later part of her life, if she continues her lifestyle changes and dietary modifications, the chances are less. But if she doesn't, then the chances they are a little bit high for her to develop hypertension.
Yeah.
So she should be on a follow-up for that. She should be
100%,
regularly.
100%,
Absolutely.
100%. Regular health checks once in a year, that will suffice, but
Yeah.
she has to do that.
Yeah.
There is another one question. Does low BP needs medication? Though our topic is hypertension.
Yes.
Low
So
BP.
low blood pressure is a very transient drop in the blood pressure, maybe because of multiple reasons. Whatever is the cause of that has to be corrected, and usually body has a reset mechanism which will correct the blood pressure automatically. That is the thing. There is no medication for low blood pressure unless there is a reason like cardiac failure or syncope which is causing that. So no, we do not treat low blood pressure actively, but we try to find out what is the cause of the low blood pressure, and that needs to be corrected.
Okay. Any suggestions for the senior citizen related to BP?
Anybody who has a high, there used to be a concept that as you grow older, you don't need to bring your blood pressure down as aggressively, but we have found that it is one of the highest risk for stroke. So we don't want the blood pressure to come down dramatically. We want it to slowly come and be maintained at an optimal level, which is 130/85 to 140/90. Whether it is senior citizen, because the risk of fall, the risk of fracture, the risk of cardiac failure and all is very high. The risk of hemorrhage is very, very high in elderly people. They cannot accommodate high blood pressure because their blood vessel is also very, very stiff. So my suggestion is that, yes, they have to keep it monitored, and we need to ensure that they are on the right track medication.
Last question, ma'am. I did a health check 2 years ago and was recommended Coversil 4 mg. I have not checked my BP since. How long can I continue the medication in case I am unable to meet my doctor?
There is no way that there is not even a single GP next door to get the blood pressure checked. Anybody who is on hypertension should be able to check the blood pressure themselves, or with a home monitoring, blood pressure monitoring, or they need to go back to their doctor. Whether he needs to continue indapamide, that is what Coversil is, please go back to your doctor, get your blood pressure checked, and ask that question there. Thank you.
That's all the questions, and thank you so
Thank you very
much.
much.
Yeah. And doctors.
Thank
you. Thank you.
you so much.
Thank you.
Thank you so much.